Hello, my name's Ian McCall, and this is a video from the dermatology for dentists and dental students on mouth ulceration. I'm mainly looking at the medical causes of mouth ulceration. I've started there by saying if I see one big mouth ulcer that's been present for a month or longer, then it's a malignancy until a good biopsy proves otherwise. And we'll come to cases of oral cancer a little bit further on, but I just want to start off by saying that any big mouth ulcer present for a month or more, then it's a malignancy until proven otherwise. Now, there are a variety of other causes of mouth ulcers, and we're going to look at trauma, aphthous ulcers, pseudoaphthous ulcers, the big Sutton's ulcer, or the giant aphthous. And then there are multiple aphthous ulcers that you'll see in Behçet's syndrome. And occasionally you'll see an ulcer with a granulomatous histology, but I mean, that's not rare now, that's not common in our part of the world. But if you do a biopsy and it comes back as granulomatous, then you should consider, I've said TB or histoplasmosis, but there's also Crohn's disease. Crohn's is an inflammatory disease of the bowel, but occasionally it'll give oral granulomatous lesions as well. Whenever you get ulcers, you've got to consider viral causes, and the common ones are herpes simplex and zoster. Zoster you'll think about if it's unilateral, it's one side of the palate or one side of the tongue. And then you've got the smaller ellipsoid ulcers of hand, foot and mouth disease. We'll look at these shortly. And then some ulcers induced by chemotherapy. Graft versus host disease, which is an autoimmune problem you'll see in people who've had transplants. That can present in the mouth as ulcers. And there's the other medical conditions of lichen planus, pemphigus, sometimes lupus as well. They'll produce ulceration in the mouth. We'll have a look at some of those as we go on. Let's look at the common things first, though. Let's look at these in this particular fashion. Here's your solitary aphthous ulcer, generally on non-stratified squamous epithelium. So usually some of the movable parts of the inside of the mouth that bound down to periosteum. You get a papule appearing first, the red papule, that breaks down to form this sort of mouth ulcer. Generally between 1 and 5 aphthous ulcers, often on the tongue, tender. They're sore. They are irritated by acidic foods or eating potato crisps or anything like that. In fact, some people may feel that these things cause them, and that the potato crisps or anything sharp irritates the tongue and causes the aphthous ulcer to occur at that point. We've got a few other examples. Here a rather big aphthous ulcer, a giant aphthous ulcer. Then small grouped aphthous ulcers here. This is almost oval-like hand, foot, and mouth disease, but grouped little lesions like that can occur as grouped aphthous ulcers. There's a couple of large ones that have been occurring in a patient with Behçet's syndrome. I'll come to that shortly. These are other small grouped aphthous ulcers. These are called herpetiform, just because they can simulate herpes simplex ulcers. But they're just herpetiform, they're not due to herpes simplex. So there's this small variant of aphthous ulceration as well, called herpetiform aphthous ulceration. And this was just an example of a giant or solitary aphthous ulcer, or Sutton's ulcer, S-U-T-T-O-N'-S, Sutton's ulcer, that can occur. Very painful, solitary, large lesion, quite deep, and it will take quite some time to heal. The ordinary aphthous ulcers will usually heal within a week, but a giant aphthous ulcer like this could take 3 weeks or more to heal. In fact, if you were still seeing it after 4 weeks, you'd need to look at that and wonder if it was a malignancy rather than a giant Sutton's ulcer. Now, if you're going to biopsy something like this, rather than a punch, you may need an incisional biopsy with 2 or 3 vital sutures there to get that examined properly. Now, if you've got multiple aphthous ulcers, let's go back and look here. Say you've got multiple aphthous ulcers like this. Go and have a look for iron, B12, and folate deficiency. Check their bloods for that, because if you correct that hematinate deficiency, you can often correct their tendency to get these recurrent aphthous ulcers. Also, you'll get multiple aphthous ulcers in Behçet syndrome. You can see these multiple aphthous ulcers here that are occurring over the soft and hard palate, which is a more unusual site for them. But multiple intraoral aphthous ulcers, you think of Behçet's. Now, Behçet's is a syndrome. So these patients will often have gentle ulcers. They'll often have iritis, inflammation of the iris of the eye, so painful eyes. And they may have an arthritis. They may have skin ulcers elsewhere. But it's a rare condition. But you still have to think of it if someone's presenting with multiple intraoral aphthous ulcers. So you've got to ask about the eye, the genital lesions, and whether they've got any skin lesions elsewhere. So remember also, with just a few aphthous ulcers, recurrent aphthous ulceration, check for vitamin B12, folate, and vitamin deficiency, and iron deficiency, I should say, and correct for those, because you can settle their ulcers if that's the case. The very large Sutton's ulcer, often you need some intralesional steroid for that to settle it down, or even some oral steroids. And occasional patients will settle with a drug called dapsone, but that drug's usually used in leprosy and in a condition called dermatitis herpetiformis, which you see in patients who've got celiac disease. But that's another issue altogether. What about other types of ulcers? These are the more elliptical or oval ulcers that you get from viral hand, foot, and mouth disease. So if you see these types of ulcers on the inside of the tongue, have a look at the palm of the hand and the sole of the foot and see if they've got any signs of them there, because it's part of hand, foot, and mouth disease. It's Coxsackie virus, self-limiting. Here you've got very extensive ulceration. You've got white sluffy material, involvement of the lips as well. Now, you could get that in the Stevens-Johnson syndrome, if it's a drug reaction. But here, this is a primary herpes simplex virus infection. And often when you get really severe oral involvement like this, it is the first infection that someone's had with herpes simplex. It's the primary infection that, and they may get over it and never get any more, or else they may be those individuals who then get recurrent little crops of herpes virus occurring in the lips or in some other area for many years. But it's often primary herpes simplex that will give you the severe involvement. It's the same with genital. When they get the primary genital herpes simplex, women can get severe involvement in the vulvovaginal area. And then later on, if they're going to get recurrent, it'll be much smaller areas. So you want to swab that and see if it's herpes. And if so, they'll need oral or intravenous acyclovir to settle this down, because they can't eat or drink. It's very, very painful. And they need some relief from, say, a lignocaine mouthwash or lignocaine gel to try and relieve the pain and discomfort here. You can see the sloughing, you see the marked involvement of the herpes virus. I mean, you can't see the actual vesicles of that. They've just all meshed up together, giving you your ulceration here and sloughing here as well. These are the sort of figurate type ulcers you get with herpes zoster, shingles. If you get that in the inside of the mouth, it may be on part of the hard and soft palate, maybe one half of the tongue, depends on the nerve that's going to be involved, often glossopharyngeal. Here, that's the sort of shallow buccal ulcer you can get from lichen planus. Now, you're used to lichen planus giving you the net-like pattern here. And sometimes it can give you a severe gingivitis as well, but sometimes it'll present with an ulcer, a buccal ulcer like this. It can be difficult to eat. I mean, I don't think you can make the diagnosis just by looking at it unless they've got features of lichen planus in the skin elsewhere. You know, the purple polygonal papules, itchy papules on the volar surface of the wrist or at the ankle. But a biopsy may help you here, but it needs to be a decent biopsy across here, an incisional biopsy with suturing. That's more classical, severe intraoral involvement with ulceration from lichen planus. You can see it has that white sluffy appearance here as well. Again, difficult to diagnose and, just from clinical appearance unless you've got evidence of lichen planus elsewhere, or you do the relevant biopsies. I mean, you'd need to exclude herpes simplex in this. You need to exclude Stevens-Johnson syndrome, erythema multiforme involving the inside of the mouth as a drug reaction. These are the skin lesions of pemphigus. Sorry, that's not a great picture. Pemphigus vulgaris will present as very fragile blisters in the skin, and they break easily, so they often present as crusts or erosions in the skin. But these patients will all have intraoral ulcers. First of all, at least 90% of them with pemphigus vulgaris will actually present with oral ulceration. I'm not sure if we've got a good picture of that here. Yeah, there we go. There's an ulcer on the buccal surface due to pemphigus vulgaris. Yeah, it looks somewhat like that lichen planus ulcer that we had. So again, fairly superficial here. Again, you'll need to do a biopsy, and in this case, not only should you do H&E, but you should do a biopsy for immunofluorescence, because if you do a biopsy for immunofluorescence, you'll see this sort of picture. These are your squamous cells here, and this is the immunoglobulin laid down around the outside of the squamous cells, because the immunoglobulin is directed against the desmoglein, the desmosomes that hold the cells together. So it's usually desmoglein 3 that it reacts with, and so you get this pattern on immunofluorescence because it's fluorescent antibody that's directed against the antibody that the body's laid down on these desmosomes that hold the squames together. And of course, in pemphigus, it's damaging this, so this all sloughs apart, and that's why you get that erosion in the inside of the mouth. That was another example of several areas of mucosal ulceration and sloughing in pemphigus. I think difficult to diagnose on its own. You have to just consider this. It'll be an elderly person, often on the buccal mucosa, like this, that type of ulceration. And if you're doing your biopsy, you're going to send it for immunofluorescence as well. Remember that picture. Oh yeah, these were the sort of little purple papules that you can get in lichen planus. I meant to show you that earlier on, but often on the wrist and the dorsum of the foot like this. And of course, this is the sort of picture that you get normally in the buccal mucosa, the reticulate net-like. It's not a great picture of that you'll see in lichen planus. So we come to that, I think, next. But as far as ulceration goes, we really have to consider these particular conditions, but particularly back to the aphthous ulcer picture and that lesion there. So multiple aphthous ulcers, they're the ones you really have to know a fair bit about. If you're a dental student, almost certainly they're going to ask you something about aphthous ulcerations. So just remember multiple aphthous ulcerations in Béchette's, solitary big aphthous ulcer, 1 to 5 in ordinary aphthous ulcerations. You can get the herpetiform type of aphthous ulceration. Check your iron, B12 and folate. Look for any areas of teeth damage that may be irritating the skin and causing that to come about. And really, I think that's most of what you have to know on aphthous ulceration. So, mouth ulcers. Remember, a big, solitary mouth ulcer lasting more than a month is a malignancy until proven otherwise, and it's got to be biopsied. Thanks very much.